Hello, everyone. We'll be starting in just about a minute or so. We'd like to let a few more people join before we start. Thank you. Okay, good morning, good afternoon, and good evening. Welcome to ICAP Grand Rounds. Today, we're going to hear about HIV recent infection surveillance, implications for HIV testing strategies in the era of epidemic control. As we know from the FIA surveys and many other projects, both lack of awareness and delayed HIV diagnosis continue to be major obstacles for epidemic control. HIV recent infection surveillance using recent infection testing algorithms in routine HIV testing services can help identify which testing approaches are effective at identifying people living with HIV and informing public health responses. So we're going to hear from Dr. Suzue Saito and David Miller on this topic. Suzue Saito is well known to many of us, nearly all of us at ICAP. She's an epidemiologist and public health specialist with almost 20 years of experience in designing and implementing large-scale strategic information systems for PEPFAR-funded surveillance and HIV care and treatment programs. She has extensive experience standing up surveillance systems to identify and track HIV-1 recent infections in resource-limited settings, most directly through her work as project director for the TRACE project, Tracking with Recency Assays to Control the Epidemic project. Suzue was also director of strategic information for the FIA project, and she is currently the director of the Strategic Information Unit at ICAP. David Miller is an epidemiologist with the HIV Testing Services team within the prevention branch at the CDC's Division of Global HIV and TB. And in this role, he supports case finding and prevention efforts in PEPFAR countries. In addition to this current role, he has experience working with CDC's domestic HIV program, the COVID-19 response, and in Guinea for the 2014 to 2016 West Africa Ebola outbreak. So we have two very, very qualified people to talk to us about this topic. So let me hand things over to Suzue.
Thank you, Jessica. Share my screen.
I'm sorry, Suzue. I neglected one housekeeping point. We don't have to have it as a slide up, but I wanted to just encourage everybody. Please use. I've forgotten. I'm sorry. The Q&A box for your questions. We're not. We prefer that you don't use the chat box for the questions. So please put your questions in the Q&A box. And a few of us, including Eugenie Poirot and our colleague from CDC, Stephanie Bahel, will help with answering some of the questions in real time. And then we'll use some of our time at the end for discussion. Okay, thank you.
Thank you so much, Jessica. You see the title slide and audio is okay? Please confirm.
All good.
All good, thank you. Thank you. On behalf of the HIV recent infection surveillance teams at CDC and ICAP, as well as our global recency partner, UCSF, I'm pleased to co-present our talk on HIV recent infection surveillance, implications for HIV testing strategies in the era of epidemic control. Our outline of our talk is shown here. David will start us off with summarizing the PEPFAR supported HIV testing strategies to provide the context in which HIV-1 recent infection surveillance is being implemented. I will then give an overview of the current status of HIV-1 recent infection surveillance and share some early insights we have learned that are particularly useful in informing testing strategies. And I'll hand it back to David to share some thoughts on implications of findings from recency surveillance on current menu of HIV testing strategies and give some concluding remarks. And we'll have a little bit of Q&A time at the end. Please do put Q&A during the talk and we'll answer as they come in. So over to you, David.
Thanks, Suzue. Next slide, please. PEPFAR has made great strides in HIV testing and the first 95. However, we still have 6.1 million that remain unaware of their HIV infection as of 2020, and there are approximately 950,000 new infections in Africa and Asia in 2020. The visual here illustrates the number of individuals tested annually since 2004, which peaked in 2018. Beginning in 2013, PEPFAR-supported sites began reporting on the number of individuals testing positive, giving the ability to track positivity or yield. In 2019, we can see that the number of individuals tested and the number of testing positive began to decline as a result of more targeted approaches to testing, and programmatic yield has averaged around 4.2%. In 2021, 2.4 million people received an HIV positive test result. Next slide. PEPFAR defines epidemic control as the point at which HIV new infections have decreased and fallen below the number of deaths among HIV infected individuals. But epidemic control is not a static state, and thus sustainable strategic combination of HIV testing approaches is critical to maintain and achieve achievements, or accelerate achievements. PEPFAR continues to work with countries at different stages of achieving epidemic control. Previous slide, still there, thanks. Regardless of their stage, PEPFAR recommends a strategic mix of HIV testing modalities to reach and maintain epidemic control, and we need to continue to base testing strategies on the country context. Major shifts in HIV testing approaches or modalities are not recommended when a country reaches epidemic control, but instead there should be a fine-tuning of HTS to optimize certain modalities that will be needed once the country achieves the first 95. Primary prevention remains a key part of the strategy to maintain epidemic control, and HIV testing is an essential element to these evidence-based interventions, so HTS can remain a vital part of PEPFAR programming. Next slide. In addition to understanding epidemiological context, PEPFAR has continued to encourage countries to focus on a combination of indicators, including the number of testing positive, testing yield, and cost per person diagnosed, not solely on the numbers tested as a measure of performance. PEPFAR also supports programs to conduct analysis by population subgroup, age, and gender to understand which factors influence positivity, linkage to prevention and treatment services, and re-engagement in care. All of these indicators are used to improve the combination of HTS approaches. Next slide. Regardless of where a country is in terms of epidemic control, we will continue to recommend a combination of testing strategies at facility-based settings. There will be populations where universal testing, or testing everyone, is important not only to achieving, but also maintaining epidemic control. Additionally, there are service delivery points where screening to determine eligibility is recommended, and we need to weigh the risks and benefits based on country context and tools available. HIV self-testing can also play an important role in the screening process, offering a trade-off of sensitivity for potentially increased costs and less control. All these strategies are reinforced with the offer of index testing services to newly diagnosed individuals and individuals who may have been lost from care and now have detectable viral loads. Next slide. Here you can see that PEPFAR has expanded the use of HIV self-testing annually for the last 4 years, and has continued to support expansion of self-testing to further amplify HTS approaches such as index testing, social network strategy, and facility-based testing. The picture here shows an example of how HIV self-testing has been integrated into the outpatient department. clients can test themselves confidentially inside one of the blue tents using the HIV self-test kit while they wait to see a provider. This particular model of assisted self-testing has the advantage of providing privacy while giving the ability to immediately refer a client for testing by the national algorithm should their HIV self-test be reactive. HIV self-testing has been particularly successful adaptation that HTS programs have made in response to the challenges of the COVID-19 pandemic. HIV self-testing is now recommended to use for reaching children 2 and older, and also for the routine monitoring of PrEP clients. Next slide. A recent article in Lancet looked at trends in HIV testing and the efficiency of HIV testing programs in sub-Saharan Africa, which highlighted the significant progress that's been made over the last 20 years. Another finding from this paper was that there's a significant number of retesting among previously diagnosed people living with HIV, which raises concerns about the effectiveness and efficiency of our HIV testing programs. As illustrated in the left panel, we've learned that there's a churn that happens whereby an individual being engaged or disengaged in HIV care is not a permanent or final state, but rather an interval that an individual may cycle through in their life. As we continue to monitor our PrEP programs, we're also seeing there's a similar churn among clients accessing prevention services. HTS programs can help to understand the individual level reasons and barriers that impact retention and to inform tailored solutions. Next slide. And click one more there, thank you. This figure shows the number of HIV tests conducted, positive test results, and HIV positive individuals newly initiated an ART from the 41 supported countries. Let's start with the number of HIV tests conducted. Click, please. In March of 2016, PEPFAR conducted 19 million tests. The number of tests conducted increased by 42%, peaking at 27 million in September of 2018. PEPFAR's updated HIV testing guidance was then released in January 2019, which shifted from universal testing to a targeted approach of testing individuals at increased risk for HIV. Overall, from January 2016 to June 2021, the 41 countries reported conducting 443 million HIV tests. Next slide, click. Now let's talk about the trend for positive test results received, shown in the orange line. In March 2016, the 41 countries reported 900,000 positive tests, which peaked at 1 million in September 2017. The number of positive tests mirrored the reduction in the number of tests conducted following PEPFAR's updated testing guidance. In June 2021, the number of positive results was 600,000. The text boxes show the percent positivity or yield over the quarters. The percent positivity ranged from 4.7% to 3.4%, with the most recent years at 4.0 positivity. Next click. Finally, let's talk about HIV positive individuals newly initiated on treatment, shown by the gray line. Prior to 2019, there was a considerable gap between those individuals who tested positive and those who were initiated on treatment. After June 2019, this treatment gap began to narrow as the number of people living with HIV initiated on treatment more closely matched the positive test received. Next click. So the question remains, where are our positives? Where have they gone? Have testing numbers been inflated by potentially people retesting? Have prevention activities reduced the number of new infections? Recency can help inform our monitoring and suggest answers to some of these questions. Turn it over to Suzue to continue.
Thank you very much, David. I'll begin by giving an overview of the HIV-1 recent infection surveillance being implemented in PEPFAR-supported countries to date. I'll start with a quick terminology review before diving into the substance of my portion of my talk. We'll be using recency and HIV-1 recent infection interchangeably. And when we say recency, it is referring to an infection that happened under 12 months of diagnosis. Note that this is not the same as acute infection, an infection which is the earliest stage of infection and it generally develops within 2 to 4 weeks. So Just wanted to clarify that. And secondly, it's important to understand that a newly diagnosed case is not the same as newly infected case. You may be newly diagnosed with HIV, but could have a recent or long-term infection as measured by the serological test employed at Recency Surveillance. Our surveillance efforts are focused on characterizing the newly diagnosed individuals with their infection period, new versus old, to inform programs, and in this case, optimal testing strategies. Throughout the presentation, we'll be making reference to HIV testing services, or HTS, which is defined as a full range of services that should be provided together with HIV testing, including pre-test and post-test counseling, linkage to appropriate HIV services, and coordination with laboratory services to support quality assurance. Recency surveillance, as you will see, is implemented in routine HTS in facility and community, in the community. Implementing recency and HTS has highlighted the issue of retesters on R, as you'll see in this presentation. And David mentioned this a little bit, who for one reason or another are diagnosed again, even after previous positive test and often already on ARCH. And finally, we will refer to case-based surveillance, which is a system to track all PLHIV from diagnosis, treatment to death in a deduplicated registry. Recency surveillance, when implemented within CBS, does effectively address retesters, especially when sites have the ability to look clients up in a centralized database using a unique ID. So data needs in the era of epidemic control versus sort of scale up are different. We are in an era where fewer and fewer infections occur, and increasingly we need granular, high quality, individual level data are needed to help programs develop. So programs will be tailored to specific gaps, and they need to effectively address harder and harder to reach subpopulations. And we really must pivot to estimating new infections, to really actually counting new infections to track progress over time in real time. Last mile programming demands great data. And I just wanted to sort of highlight, FIAs have been incredibly rich source of data to evaluate national and population level impact of programs and monitor prevalence, viral load suppression, and the 90-90 or 95-95-95 cascade, as well as national incidence over time. In terms of new infections, though, during FIAs, we only detected about 10 to 50 recent infections per survey after enrolling 20 to 40,000 people, and in some cases, really single-digit cases in a number of countries. So with such small numbers, further analysis that can help program tailor interventions is limited. And here is where the utility of recent infection surveillance comes in. It's a nice complement to the FIA surveys. The surveillance system, that the HIV-1 recent infection surveillance system is anchored in rolling out a new rapid test for recent infection, or RTRI, which is a rapid test that distinguishes recent infection from a long-term infection among clients presenting for HIV diagnosis at age 15 and older. The cutoff used in the assay that is widely used around the world, shown on the right, is 12 months, where a recent infection is an infection acquired less than 12 months ago, and a long-term infection is an infection acquired 12 months and longer ago. RTRIs are not recommended for use in retesters on ART, which is estimated to account for 30 to 50% of clients presenting for HIV diagnosis in many HIV programs. In this context, use of recent infection testing algorithm, or RITA, is important, where those who test RTRI recent have their baseline viral load measured, and those who have baseline viral load with HIV RNA of 1,000 copies per ml. Oops. Sorry. are assumed to on ART and reclassified to not having a new diagnosis. So anchored in the RTI or RITA, there are several other critical components of the recency surveillance system being rolled out. First, the location of the testing can vary from HTS, both facility and community, with verification before ART initiation or on-site labs, as well as hub labs where samples are shipped from HTS for testing. Recency surveillance can be implemented in routine HTS as well as case-based surveillance. Second, in terms of a return of RITA results to clients, because the results are not clinically actionable to an individual client, most countries do not return these results to clients and use the data for program improvement and public health response purposes. A handful of countries do return RITA results to clients due to country legal and policy requirements. Third, for recency surveillance, obtaining near real-time data on recent infection is critical. And electronic data capture and timing analysis is the norm with very little reliance on paper systems. Fourth, the surveillance teams Fourth, the surveillance teams in country use the dashboard that are updated daily to make program and public health response decisions. And these data are shared at least monthly with HIV programs to inform programming. And in a few countries, public health response activities to just address large clusters of recent infections have taken place. And finally, as part of post-market surveillance, we conduct and collect data on monthly site level QC of the RTRIs and 6 to 12 month proficiency testing. To date, PEPFAR is supporting, I think now it's 33 countries to implement recency surveillance, and ICAP supports 16 of them to establish the recency surveillance systems. The last time we checked data.pepfar.gov, we were doing 48,000 tests per quarter. And the map shows those countries that are implementing in green, and in blue training, and preparing in yellow. So now I'll share some programmatically relevant insights from recency surveillance we have gained thus far. We say early insights because we stood up recency surveillance largely in 2019, 2020. And with the COVID pandemic, in many countries, the surveillance systems were put on hold. And so we are really looking at 1 and 1.5 year worth of data in most countries. So we'll talk about 4 key insights. First is really, we have seen recency surveillance to be useful in monitor trends as a tool to monitor trends in AGYW, as well as men who are missing from the surveillance system. And second, because the surveillance system is really anchored in routine testing services. And second, as I have alluded to in earlier slides, recency surveillance had helped quantify and describe the retesting population on ART, and we'll share some data here on that. And third, recency surveillance has been important to highlight the predominance of long-term infections in the newly diagnosed population, and we'll show some data. And finally, we'll share some data on recency and modality of testing and the importance of outpatient departments in this context. The graph here, it's a busy slide, so bear with me. I'll walk through this. Show the number of RTRI tests done in the primary vertical axis. Primary vertical axis here. And with green shaded bars indicating females of younger to older age groups from darker to lighter. So if we look at country B, this is the 15 to 24 female group, and progressively the older age groups. And blue shades bars representing males of younger to older age groups, from darker to lighter shades of blue. So this is here, so darker to lighter shades, young males, older males. The secondary vertical axis is proportion recent among tested. So the bubbles or the diamonds represent proportion recent, and this is the secondary axis. So for country B and C, for example, females represent the majority of surveillance population. I mean, this is shown because we have more greens. The proportion recent is highest in the youngest population and declines with age in both females as well as males. Note that country C, on the other hand, the percent recent is higher, primarily because RTRI implementation is without viral load. So these are high numbers because there's no viral load correction for retesters. For country A and E have a different conclusion. In country A, females and males are more equal in representation in the surveillance population, shown by the roughly equal heights of green and blue shaded bars. The percent recent also appears to not follow the clean descending by age trend. In country E, on the other hand, males are the majority of surveillance population, potentially because the program as a whole is focused on KPs, and hence the recent surveillance population also reflects that focus. That's on this side. So this graph focuses now, so I'm changing focus here. We're using kind of the same schematic, but this is now just focused on recent cases and age and sex distribution. So it's not among tested, this is just showing recent cases. And there are several observations to make here. The recency surveillance systems are identifying hundreds of recent infections within a year to 2 years in these countries, permitting in-depth analyses in each country's unlike FIA. So I just wanted to make that broad point about just the sheer numbers of recent infections we are identifying in the surveillance population. Predominance of young females, particularly AGYW in a recently infected population, confirms other programmatic and surveillance data. But in country F, for example, despite the amount of testing focused on males, so this is actually the same country as the previous slide, we saw that more males were being tested, but here you see, in fact, more recent cases are being identified in females. And so this really does warrant some in-depth discussion around programmatic focus. So yeah, pointing to the really, we're testing enough males perhaps, but we're not testing enough females in terms of recent infection surveillance. It needs to expand. In country A, older females and males account for a substantial proportion of recent infections, contrary to findings for other countries. So that's this country where it has a very different look as the other countries, where there's recent infections both being identified both in older males and older females. So in summary, for this portion of the slide, the number of recent infections identified can allow for granular analysis because of the sheer numbers of recent cases we are identifying, and really complements FIAs and other sources of data. Recent infection surveillance population mimics the HDS populations naturally because that's where things are implemented. But the majority of recent infections are found in younger women under 35, in particular AGYWs. And recency surveillance is a tool that can be used to really monitor the impact of DREAMS and other programs over time. It's a continuous surveillance program that, where AGYW is captured well and can be used to sort of monitor trends and impact of programs over time. Men of all ages are in most countries, there were some exceptions as I highlighted, but in many recency surveillance based in HCS, men are underrepresented, not represented fully. And we do need to find ways to expand recency surveillance to capture men better. So pivoting to the retesting data that we have, we've seen a substantial proportion of persons who test recent on RTRI assays are virally suppressed following viral load testing and are subsequently reclassified to long-term infection or not newly diagnosed. And these individuals represent persons who very likely were previously diagnosed and on ART. For the 5 countries implementing RETA that we support, 37% to 56% of newly diagnosed with a recent infection on RTRI are reclassified as long-term following viral load testing, an indication that they may have ARVs in their blood and seeking repeat testing for various reasons. We've also seen in the recency data that a substantial, so we've also, in some countries, we are able to do viral load testing on long terms as well, so not just the recents. So this is a slide from a country that does that, and we have seen substantial reclassification in the long terms as well. So about 30% without not much difference between females and males. So I wanted to highlight that the reclassification is really a broad issue among newly diagnosed, not just the RTRI recents. And we wanted to look deeper into this reclassifier retesting population. And this is a poster from ICASA that looked at correlates of retesting in Eswatini. And we applied bivariate stepwise forward multivariate logistic regression to estimate the relative risk of being reclassified long-term or reclassified as a repeat tester. And here I'm showing sort of the upshot of the reclassification data. So we saw sort of older people having a higher reclassification rate, as well as females having a slightly higher reclassification rate. And this is the result of the multivariate model data. We looked, the period of analysis is July 1st, 2019 to April 15, 2021. We find that receiving HIV testing after stay-at-home orders for COVID were issued through community HIV testing services was also strongly correlated with retesting. Pregnant women were also correlated. Older age were also correlated significantly with retesting. And this is a data from a country. This is blinded because this is routine data. We have also found community testing to have very high reclassification. In this cut of the data from this country, we had 75% of RTRI recents were reclassified to long-term. So that's a very high number. I wanted to say that the Eswatini analysis showed that, but also in another country, we have seen the same thing. Finally, this graph shows the trend in retesting over about 2.5-year period where targeted testing strategies were being implemented. We have not seen any change in retesting over time, although with COVID and mitigation measures affecting implementation of various testing strategies, I think it's too premature for this conclusion. But just to say that we are monitoring trends in retesting and to see if the declining number of positives that David talked about can be explained by more efficient testing and less retesting. We have not seen evidence of that yet. So to summarize, the challenge of retesters on ART, we have high reclassification suggesting that non-disclosure of prior diagnosis on ART use is common in routine HTS, impeding efforts to identify new infections versus long-term infections. Recency surveillance, though, through utilization of RETA, can quantify and describe retesters on ART to improve efficiency in testing strategies. I think use of CBS is a critical piece, and also improved screening tools. And we can use recency surveillance to monitor the impact of these improvements we make. Moving on to our next analysis from Eswatini, which was also described in the IS poster, is examining correlates of long-term infection. So as I said earlier, we have seen among the newly diagnosed who undergo RTRI, we see a predominance of long-term infection. About 80 to 90% of testers are long-term. And we wanted to understand the correlates of long-term infection in Eswatini. We analyzed about 6,000 RTRI results from 113 sites in Eswatini during July 2019 to September 2020. As I said, about 90% were LT long-term infections, and the main results of analyses are summarized by the forest plot here. In adjusted analyses, as indicated by the yellow boxes, male sex, clients who were older in age, residents in a whole region, clients who do not report testing history. So this is self-reported data. So first-time testers were correlated with long-term infection, and clients who reported not ever using a self-test kit was also correlated with long-term infection. We also looked at distance to travel for HIV diagnosis, marital status, education, injection drug use, number of partners in the past 12 months, and experiencing forced sex. Those were not correlated with long-term infections. Yes, and these are self-reported data. I just wanted to make that point again. So in terms of conclusions, vast majority of newly diagnosed clients identified in HTS have a long-term infection, not a recent infection. And it appears lack of access to testing, particularly self-testing, correlates with long-term infections. That could be a lesson learned for testing strategies. And finally, we examined, I wanted to sort of describe and this was described in a oral presentation a month ago. We examined both share and yield of recent cases by testing location or modality to identify locations that appear to be particularly well suited to identify recent infections. And we used recent infection surveillance data from DRC, Eswatini, and Lesotho to measure share and recent cases, which are defined here. So share, when I say share, it means number of RITA or RTRI recent cases at a testing location. This is VCT, OPT, et cetera, over total number of RITA or RTRI recent cases in the country. And yield of recent cases is the number of RITA or RTRI recent cases at a testing location over the total number of RITA or RTRI at that particular testing location. Here we show the share. Oh, gosh. No, sorry. That's the audio from the course. Here we show the share of recent cases by testing location. In all countries, OPD accounted for the largest share of recent infections identified. In Eswatini, VCT and index testing were additionally significantly associated with identifying recent infections. The predominance of OPD remained in age-sex disaggregated analyses, with the exception of females under 30 years in Eswatini, for whom ANC, L&D, postnatal care testing, child welfare clinic testing were additionally significantly associated with identifying recent infections. And we didn't see this in DRC or Lesotho. It was an Eswatini specific finding. Here we show the yield of the red dots represent yield. Sorry. What's happening? Yield of cases were highest in family planning. Sorry, you have to. Antenatal in Suzue. However, testing volume in these settings are very modest. So there you go. In conclusion, outpatient departments is a critical testing location to identify recent infections in diverse settings, including Lesotho and Eswatini, that have reached epidemic control, as well as in DRC, which has still yet to reach epidemic control. Recency testing can inform HIV testing efforts in OPDs to improve efficiency in testing with, for example, improved screening in countries at epidemic control. However, I think the important thing here is OPDs will continue to be an important testing location to maintain the gains made to achieve epidemic control. Family planning, STI, VCT, ANC, labor and delivery, and other clinics have higher yield in some settings. However, the number of recent infections identified were modest and with potentially limited program impact. HIV recent infection surveillance can generate data and analyses that can help inform testing interventions to reach and sustain epi control. So I'll hand it back to David for implications for HIV testing strategies.
Thank you. And next slide.
Do you see the informing future testing strategy?
Do you see the slide?
Yes.
Okay, I don't see it, so I'll just go for my notes there. So timely diagnosis is critical for achieving and maintaining epidemic control. Despite achievements in expanding and differentiating HIV testing approaches, a projected 50% of all people living with HIV will not be diagnosed within 3 years following their infection. This reference to the Lancet article. As countries reach 95% diagnostic coverage, there's a need to think about additional indicators beyond cost, yield, and numbers tested to measure the success of HTS going forward. This can now include indicators such as proportion testing recent or long-term, with each measure being important in guiding how prevention and case-finding services are planned. I don't think anyone is seeing the slides moving.
Really?
I see the pie chart still.
Yeah, I agree.
Is it a delay? So you didn't see the, do you see now?
I didn't see the importance of OPD or your other.
Oh, God.
No.
Okay, let me just stop sharing and then share again. Oh, it's, I feel like, Marissa, are you controlling the? Okay, I think somebody else is sharing now, sorry. Marissa, can I share my screen? Here. Do you see this now?
Yeah, I do. Thank you.
Apologies.
Oh, no worries. So as I was saying, recency surveillance can be used to characterize the timeliness of HIV diagnosis and provide insights critical to assess and improve current testing prevention strategies. Give people a moment to read that slide. And next slide. Recency data can be triangulated with other data sources to target case-finding efforts, demonstrate the impact of prevention activities, and inform on system challenges and misconceptions that might lead to retesting. For example, a high proportion of recent infections among AGYW is a signal that we need to do more to reach them with effective prevention services. Beyond using readily available demographic data and geographic data to target testing and prevention services, collection of risk behavior data can allow for more precise targeting of at-risk subpopulations. This is not without its own challenges, such as the timing of a client's risks with their HIV infection. For example, characterizing a recently infected client as a person who injects drugs when their drug use was in the past, but their recent risks were sexual would be a potential misclassification of them as we're looking at this. And finding safe and ethical ways to collect risk behavior that don't put an additional burden or discomfort on vulnerable clients. By examining recency rates across service delivery methods, we can seek to target services earlier in the service delivery stream, directing PrEP demand creation to active transmission populations or HIV self-testing to populations who are found much too late. Further, recency surveillance can help inform our strategic mix of testing strategies. Contrary to previous assumptions that facility testing typically finds individuals late in their infection, we see in the examples presented here that testing in OPDs is effective at identifying cases earlier and may be an important service delivery point to sustain once countries reach the first 95. Finally, HTS plays an important role in re-engaging persons living with HIV who are not currently on ART back into care. However, programs should reduce unnecessary testing of retesting of known positives, and this can be done through continued scale up of case-based surveillance or use at point of care testing sites and using recency data to inform follow-up assessments that can lend additional insights as to reasons why people are retesting. Next slide. To summarize things, while there's been great progress in HTS, the first 95 remains challenging, both in closing the gap and maintaining our gains. Being able to quantify and characterize HIV diagnosis is critical, especially for countries at or near epidemic control. Recency surveillance, routine monitoring of HIV testing programs by providing unique and valuable information on HIV diagnosis works in several ways. Recent infections can signal the ongoing transmission and an effective testing strategy given earlier diagnoses. Long-term infections signals delays in HIV case finding. And reclassification from RTRI recent to RETA long-term is a signal of retesting. Re-engagement requires more attention in our HTS and care and treatment programs. And recency signals should be triangulated with other surveillance and program data sources. Investigating these signals can identify gaps and inform data-driven programming and public health responses that are tailored, dynamic, targeted, and more effective. And next slide. I just want to give our acknowledgements and thanks to all the people that helped support and put this presentation together.
Okay, well, thank you both for a really excellent presentation. The Q&A has been very active, and thank you also to our many panelists, including those with CDC who have been fielding a number of the questions. So we do have time, I think, to discuss a few of these, and I wanted to start us off with a question that came in from Connie Kellum about using recency testing to help us understand what HIV incidence might look like. And let me just scroll back to Connie's exact question. Give me a moment. Sorry, there it is. Can you comment on insights from monitoring dreams through recency testing? Is there a recommended number of adolescent girls and young women who would need to be included to have enough precision about estimated HIV incidence from recency testing to make conclusions about trends and needed targeting? I mean, this is certainly a topic we discussed quite a bit on the TRACE team. Suzue or David, do either of you want to respond to that one?
David, do you want to go?
I'll let you take that one.
Wait, sorry, I was just reading some other question. Can you repeat the question, please?
Sure.
Which one?
Sure. Sure, it's from Connie Kellum, and it's about the relationship between recency testing and incidence estimates. What Connie specifically asked was, can you comment on insights from monitoring dreams through recency testing? Is there a recommended number of adolescent girls and young women who need to be included to have enough precision about estimated HIV incidence from recency testing to make conclusions about trends and needed targeting?
So I don't think we're using recency, the rapid test version, to estimate incidence yet. The day may come. And I think there was a poster, was it last year, where lag was used in a kind of to estimate the control arm, to use it as a control arm in a clinical trial monitoring PrEP efficacy. So I'll try to find that poster and send it to you. I think that might be the only sort of implementation of recency assays. I think, but the recommendation, I think, is using lag. In terms of recency, I think what we are going to do going forward is what we showed today was like RTRI, counts of RTRI or RETA recent over tested, right? Those who are newly diagnosed and got tested, so proportion recent of newly diagnosed. And that has a lot of issues with, retesters, as I showed. And I think we're going to start using more of a proxy for at-risk population. So it's not incidence, but it may kind of track incidence if we use at-risk population as a denominator. And that we've done this, so and at-risk population as defined as people who were negative, tested negative plus recent. And we have used this in a few countries, and it does seem to be more stable and can be a more useful indicator. So hopefully we'll have another round of data to show in the next opportunity we have.
Sure. I think, Suzue, just to kind of highlight what you're saying, particularly not using the term incidence, because it really isn't the same as incidence. It's similar, and I think it can shed light on the epidemic, but I think it's probably going to be better not to call it incidence because it's very different in terms of the denominator. So, okay. Let's see. There was a question here from Mary Mahey asking for more clarification about how recency can help identify missing men.
Oh yeah, I think that was probably the way I said it was not clear. No, I think we're just showing how when you just look at recency surveillance implemented in testing population, you see the same gap as you see in the program, right? And so it's a limitation. But we can use recency surveillance and to monitor if we get better at it, right? So if we start using some innovative testing strategies that can capture men, we should be able to sort of reflect that in our surveillance population. We are definitely underrepresenting men in most of our surveillance population, except in that one country that I highlighted where we are doing really well, and that's a program very focused on key populations. So in that context, we are able to represent men, and we may have some lessons learned from there. But yeah, no, I think what Mary understood is correct. We are definitely missing men.
Okay.
This is a great area where we can use the triangulation of data. I mean, as we look at our HIV testing data, we can see which avenues and modalities are men more apt to access. And also we can look at places that implement programs such as men focus hours at clinics, and see if that is bringing us more that way, so we can back up from there and then realize these are things we need to re-emphasize more.
Okay, great. There's a question from Musa Manganye looking for more information about the data from OPD, outpatient department settings. What do we know? Whoops, it just disappeared on me. I think it was asking more about a breakdown by male, female, and yes, please, if you would just expand on that a little bit.
Yes. So we did look at, these questions around are certain testing locations better for men or women in terms of identifying recent infection cases, right? And so we looked at it, and I did mention, and I'm sorry, those slides were so botched, that in Eswatini, we did find, ANC, PNC, LND was an important testing location to identify recent cases among pregnant women, and that became a significant finding. We didn't find that in DRC or Lesotho. And what I said about OPD was across the board, slicing and dicing in different ways was an important finding, regardless of which age, which gender. So I think it's an important testing location, just regardless of age and sex.
Okay, okay. There is a question from John Stover commenting that Eswatini has a very high knowledge of HIV status, and how does that reconcile with most new diagnoses being long-term infections?
Yes, we have the same question. And I think the country program has had the same question. Don't
we think this is a lot of retesting then?
That is possible. So I think that's a country where so we've captured about 40 to 50% reclassification or retesters in the recent RTI recents. We don't do that in the long terms. That's a country probably maybe we should do it as a study or something to just see. And the testing program, I don't know if there's a MOH colleague on the call, but I know they're putting a lot of emphasis on screening and making sure they have a handle on retesting. They've introduced a screening, a flow chart job aid for providers to better screen out retesters. There's sort of messaging changes in their pre-test counseling that sort of encourages, don't stigmatize people who are retesting, but to try to draw them out and acknowledge that they're coming for retesting and try to sort of classify them properly. So there's a lot of work around trying to reduce retesters. So maybe we might see a difference, and we should be able to track that through our surveillance system. Over.
Okay. I think we probably have time for one more question. And I'm going to combine, there's a question from Irene Benish, and we'll see if it works well with Bill Reedy's question. So Irene asks about speaking to the benefits of recent infection surveillance for key population programs and how this may contribute to strengthening programs in concentrated epidemics. Bill Reedy is talking about the slide that showed how country A had a very unique distribution of recent cases across age groups, with a lot of recency among older age groups. Why might that be? Are there differences in the testing strategy? Does that relate to key populations or something completely different? So putting those two questions together.
David, do you want to go first?
This is not one of the areas I've looked at that closely, so I feel like you have.
Okay, or just you can also take the two questions separately if you prefer.
Yeah, so in terms of the key populations, in a number of countries in Central America and the Asias, I think it has been incredibly useful. And I know we've had a TRACE webinar where a representative from Central America spoke about how recent infection surveillance highlighted unexpected high transmission among older men, MSM, which was surprising and which led to some programming sort of adjustments. So that's one way, recent infection surveillance has informed program change. In terms of Bill's question, I think we're not prepared to say one way or the other yet. It is very curious that older women and older men we're picking up as having many new infections compared to younger people. We have to rule out various things, retesting, quality of testing, et cetera. So we're looking at that, but it is we hope to have answers in the next couple months.
Great. Well, thank you.
Chime in briefly on Irene's question, which I think this also highlights the earlier slide where I talked about the importance of getting risk behavior data, like how to identify what is actually a key population when we're doing recent testing. Because if we're just going based off of clinics, age, and sex, we may not capture that kind of level of detail unless we're looking at KP specific clinics, or we find some safe and ethical way of collecting that risk behavior data to match it to their population.
Okay. Well, thank you, everybody. And we've had a very active and rich set of questions coming in from our audience, which is terrific. Fatima, can I hand this over to you now, please?
Sure. Thanks, everyone, and thanks for the great dynamic question and answer session. Just to let you know that the session has been recorded and will be posted on the ICAP website. And we will be circulating an announcement for our upcoming Grand Round session in April. So thank you again for everyone for your questions and for your participation in today's session. Have a great day.